So could we check if you hear me? Because I can't hear you.
Can you hear me now?
Yes.
Oh, great. Fantastic.
Yeah.
So good afternoon, everyone. And it's afternoon here in Ghana, I guess same in Ireland. We are welcome to this presentation on pregnancy-related anxiety, validation of the adapted pregnancy-related anxiety scale in Northern Ghana. This was research that Ghana Medical Health was involved in with the University for Development Studies in Tamale, led by Professor Gilbert Abiru and Professor Christine Hartfield, as well from the Trinity College of Dublin, the University of Dublin in Ireland, and Marge, who is leading the presentation today, who out of this did some work in a MSc program. So we are excited today to have Juanita present to us this validation of the adapted pregnancy-related anxiety scale in Northern Ghana. We are currently having our maternity service agenda emergency obstetric and newborn care conference happening in the Upper West region of Ghana. And we have in attendance about 45 doctors in maternity, obstetrician gynecologists, and midwives in practice. So participants kindly join me in welcoming Dr. Juanita. Kindly take us through the presentation. As we always do with all our webinars, kindly take note of your questions, your comments, your questions, and everything. You can put it in the chat box, or you can take note of it so that at the end of her presentation, you can have a discussion around it. However, if you would forget or you need a pressing issue to be highlighted, please make use of the chat box. Because once Juanita does start the presentation, I would disable your ability to unmute yourself so that we won't inadvertently be bothered with some background noises. So we are grateful today that you could join us. Dr. Juanita, we are all set and ready for you. Thank you so much.
Okay, thank you for introducing me. Again, I'm Majd Kamnita. I'm a medical doctor from Palestine, and I hold my master's degree in global health from Trinity College of Dublin. Today, I'm going to share the finding for validation of adapted scale for the pregnancy-related anxiety scale, which was done in northern Ghana. This was the third stage of the project, where the first and two stages I will go through like rapidly, but mainly I will show the results of validation of the scale. I will go ahead to speak a little bit about pregnancy-related anxiety and how it's measured, then what was the research aim, methods, results, discussion, and then like some recommendation. And again, feel free to write notes and any question to share with me by the end of this presentation. First of all, anxiety disorders are, like in general, presented in 15% of pregnant women, which is known that is higher in third trimester. And a woman in low middle income countries showed higher incidence in anxiety disorder in comparison with high income countries, where the rates are 34% in comparison to 19 in the high income countries. And pregnancy-related anxiety, simply it refers to anxiety experienced during pregnancy, which related to concerns about labor and about maternal fetal well-being, healthcare access, and parental readiness. Pregnancy-related anxiety in the literature showed a significant relation with several adverse effects on maternal and neonatal outcome, as it was linked to preterm labor, low birth weight, poor maternal-child bonding, impairment in the child-even development. So this all linked to pregnancy-related anxiety, where it was not linked directly to other anxiety disorder. And this also make pregnancy-related anxiety as its own context distinct from other mental health conditions during pregnancies. Researches in low and middle income countries, especially in Ghana, remains limited, especially because there is a lack of culturally sensitive measures. Pregnancy-related anxiety scale is a scale that was firstly developed in Austria, and the scale includes 33 items across 8 factors, which is childbirth concerns, body image concerns, attitudes toward the childbirth, worry about motherhood, worry about acceptance of the pregnancy, anxiety indicators, attitudes toward medical staff, and baby concerns. And just to note, the full scale, the full pregnancy-related anxiety scale is also in the reference for you to just see it first, how it was. Then the pregnancy-related anxiety scale could introduce new areas that was not addressed in other anxiety tools. Psychometric evaluation has been done in Australia for this scale, showed a good content validity and showed that it is consistent among the population and reliable, ranging from good to excellent. And Bronton et al., which is the study that published the pregnancy-related anxiety scale in Australia, emphasized that there is a significant need for cultural adaptation of the pregnancy-related anxiety scale, which has been applied in several populations. Like there was published a Turkish version, Japanese version, and even a German version. And this also gives a notification that even the European countries sometimes would differ in their interpretation about anxiety during pregnancy. And here you can find the Turkish version and even the German version about the pregnancy-related anxiety scale. The project first did a systematic review, and also it will find it in the reference list. This systematic review looked for, like they used measures to measure the pregnancy-related anxiety, especially in low middle income countries, and it found that there was no validated scale, especially in northern Ghana. Then a qualitative work has been done, and it's also mentioned in the reference list. So the main pregnancy-related anxiety scale was translated and reviewed. Then focus groups and interviews were done to result in 52 items pregnancy-related anxiety scale. It was 33 and it's now 52, where there is items deleted, which showed that there is no like significance related to women in northern Ghana, and there is more items which appears to be more triggering. And then data were collected, and I worked in validation of this new 52 item pregnancy-related anxiety scale. The main like aim for this study is to validate the newly adapted pregnancy-related anxiety scale. In other words, to see if this scale really measure pregnancy-related anxiety in northern Ghana women, especially in this context. So here you can find a new themes added after the adaptation, which was done in northern Ghana. And again, you could just refer to the big study that was published about the adaptation. And it appears that women in northern Ghana care about naming ceremony, which was not mentioned in the pregnancy-related anxiety, like the original one, and spousal support, household support. They were worrying about stigmatization if they're going through CS, the cost of care, special personal circumstances, the transportation, and really worried about spirituality and birth preparedness. While, for example, the body image concern was not triggering, and it was deleted from the adapted scale. After the revision of this data, and surveys was done, the surveys was done according to language preferences, where most of people prefer to do it in Dagbani language. The participants in the survey were 586 pregnant women, and they were sampled in a clustered random sampling, and according to this three Sibling and Mayon and Timel Metropole, which like mostly the same percentage among the three locations and also among three health facilities, hospitals and health centers and community-based health primary service. And you could find that the average gestational age for the participants were 6.6 months, and like more than 50% were in their third trimester. Each woman more than 16 years old and speak both languages is included. What we measured some demographic data, age and gestational age, and also we used several scales. We used generalized anxiety, and these all scales before mentioned, we used just to see how there is a convergent validity between the pregnancy-related anxiety scale and other scales. So we used generalized anxiety scale, which is 2 items. We used the Warwick-Edinburgh mental well-being scale, and also we use Edinburgh postnatal depression scale and the Stress-Kessler scale, and also the pregnancy-related anxiety scale, which we use the 52 items which were adapted to Northern Ghana population. And we, in just like briefly, we use the Cronbach alpha and test-retest analysis to test the reliability. We also used factor analysis, exploratory and confirmatory factor analysis to examine the internal validity, and again, Pearson correlation analysis to just measure the convergent and divergent validity. And it measures how there is a relation with anxiety disorders, and also how it's divergent from another well-being mental health. The result was that first, after we did exploratory factor analysis, we did a new scale, which is a 22 item and 9 factor. And this shortening is to make it more applicable and easier to use. So a new scale was refined to have 22 items and 9 factors. Then for this new scale, we did a confirmatory factor analysis, which validate this scale to the Northern Ghana population. Also, the scale demonstrate a full invariance across age, gestational age, and parity. And this was when we just divide the sample into groups. The first group for age, we make it less than 24 and more than 24, according that in the literature, women who are more than 24 years old has higher risk for anxiety. And the gestational age, we choose to have the first and second trimester in one group and the third trimester in the other group, again, because the third trimester is higher in pregnancy-related anxiety. And parity group, we choose to have a prime parous woman in a group and others in the other group. The pregnancy-related anxiety scale, the 22 item, showed to have a relation with other anxiety disorder, which strengthen the convergent validity about this scale. And it was reliable, and retest reliable also was strong. And this was done again when we, after 2 weeks, we get a small sample of 45 women and run the scale again, and is reliable also in the second round. This is for your reference. This is pregnancy-related anxiety scale, 22 items. This is the final version of our scale, and it's in both languages. like to discuss the results that we have. First, there is a difference in the pregnancy-related anxiety concerns between Northern Ghana women and the high-income countries. There was some shared items like people worries about childbirth, concern about taking on responsibilities of motherhood, and also anxieties about medical staff and worry about the baby's health. There's some things that were exclusive for high-income countries, which was body image concern, acceptance for the pregnancy, some avoidance factors, and also anxiety indicators like panicking without reason or not feeling continent. But what was unique for Ghanaian finding that fear of being stigmatized, for example, or labeled as unfaithful if they considered having a cesarean section, concern also about childbirth expenses, like economical concerns were higher in Ghanaian finding, and the possibility of paying for maternal health services. When we were discussing the results, lower depressive symptoms were associated with pregnancy-related anxiety, and also there was a negative correlation between pregnancy-related anxiety and well-being. And this could be explained because first, the Edinburgh postnatal depression scale are also the well-being scale that we used were not fully capturing the aspect of perinatal mental health relative to pregnant women in Northern Ghana. In other words, those scales are not validated for specifically for Northern Ghana women. And another possibility is maybe during the translation and baggage translation for this measure, there have been some issues which could affect the results. And this also could encourage to have more validity studies, not only for the pregnancy-related anxiety scale, but also for other scales that could be used widely in Northern Ghana and in other countries. How to conclude this and how we could use this pregnancy-related anxiety scale address a gap in the culturally appropriate tools to assess pregnancy-related anxiety in women in Africa, especially in Northern Ghana. This also provide an understanding and assessment of pregnancy-related anxiety and how it differs from high-income countries. And it's a potential to improve the identification and support for the pregnant woman experience anxiety, contributing to better maternal and neonatal health outcome. And this also allow for wider evaluation for intervention in order to just reduce the pregnancy-related anxiety. So really, it's recommended that this scale could be used to explore predictive validity and also to have more cohort or longitudinal studies on a larger sample size, more representative sample size, and also to study how it's clinically applicable in Northern Ghana. So this is the reference list. And this is a very simple, rapid, small presentation about what has been done. And I'm open now for your questions. And thank you.
So, Juanita, can you hear loud and clear?
Yeah, now I hear you.
All right, fantastic. Okay, so thanks so much for an excellent and concise presentation of the findings. In the chat box, those of us who are online, you can electronically put up your hand. I will unmute you to ask your question. Or if you want to make use of the chat box, you can put your comment there as well. And then we'll read that out for Juanita to answer. Those who are in-house, I'll ask them as well if there are any questions, then they will draw closer to the speaker, the microphone, and then talk about it. So we'll take questions first. Those online, if you have any question, kindly electronically put up your hand, and then I can unmute you. I will unmute you to ask your question. Online participants, if you have any question, comment, suggestion, kindly put up your hand and then we can unmute you. I've actually just enabled you to be able to unmute yourself. So please go ahead. You can unmute yourself and then ask a question if you have. In-house people, anybody with a question, comment, please draw closer to the laptop. Yeah, so I see in the chat box. So Juanita Alfred Aqua is asking, did the research try to find out why some women were labeled unfaithful because they had CS?
Actually, we didn't go deep in this. We just were looking for what's triggering or what are the concerns for women there, and just to get with a new adapted scale that could measure anxiety in women in northern Ghana, but like why they are feeling unfaithful due to CS. We didn't just go on other like words. We didn't do a correlation study between these items and why that's happening. So this was not the aim of the study.
Great. Thank you for the response. Anyone with any question? Yes, electronically. You can actually unmute. You don't need to put up your hand. Yes, unmute and have a go. Frank Abu Emmanuel, kindly unmute and then go ahead, sir.
Yeah, thank you very much, Mr. Dominic, for the opportunity. I want to find out what was the reason for this this scale in the first place, because we have the DAS that has 42 items and has now been scaled to 21 items. The DAS stands for depression, anxiety, and stress. That is equally validated enough to assess emotional states in pregnancy, as well as the anxiety, stress, and depression. What is specific about this pregnancy associated or pregnancy anxiety scale that we have to validate it in Northern Ghana? What does it bring?
Okay. Pregnancy-related anxiety as a context is different than anxiety or depression outside of pregnancy. So what this scale is trying to find like anxiety specific related to pregnancy factors, especially even if it's like at the meso level or it's at the family level. So it's disconnected from other mental health issues, like it's distinct from depression or anxiety. And it's found that pregnancy-related anxiety related more to adverse effect during pregnancy rather than other mental health like context. I don't know if I did answer your question, but that was done in 2019. The first validation was for a scale for pregnancy-related anxiety in Australia. Then when this scale was like first started to used as a screening tool for pregnancy-related anxiety, like early detection for any anxiety symptoms or signs during pregnancy, then it was found that it need to be culturally adapted to just pick up the concerns that are related and specifically sensitive to culture. So this what is significant about the scale, and it's really still open to more qualitative work. I do understand what you are asking about, but it's open to more qualitative work, for example, to add more items or to even delete items or factor. It's still a sample size of 500, so it can't be generalized as clinically used, but it's the first step that you could continue on.
Great. So thank you, Dr. Abu, for the question, and thanks, Juanita, for the inputs. So just a few other comments in the chat box. I think we've answered from Alfred. Next is, so Charity says, thanks so much for a wonderful presentation. Stella, thanks for the presentation. Please, did the research work find out if the cost of service, health workers' attitude, and the condition of the facility environment? So three factors: the cost of service, health workers' attitude, and the condition of the facility environment. If these three were contributory factors to some of the pregnancy-related anxiety.
Yes, this was related to pregnancy-related anxiety in northern Ghana, and it was more significant in northern Ghana rather than in high-income countries.
Great.
Yeah.
So thank you so much, Stella, for your question, and thanks for the response. Then we have Helena Obiniwa. Must every pregnant woman have to go through this scale, or it has to be for a specific client?
Again, it's a screening scale, but it does not have its clinical validity. So it needs to have longitudinal cohort study to say what are let's see the grade or the score that if a woman did it and has, for example, this score, is that anxiety or is that just alarming notification or so on. So it still does not have this worldwide guideline if every woman need to do this or not. So this is again the first step that we could continue on to have this scale as more clinically valid in the medical settings. But the pregnancy-related anxiety scale, the main one, is used for every woman in the antenatal care in high-income countries for screening if she has pregnancy-related anxiety or not. But I can't say that this one that I am today sharing with you is clinically valid and you could use for screening. It's just a step that you could use for a wider study to say, yes, this tool could be used to screen for women in each once, in high-income countries. In Australia, for instance, they do it once in antenatal, in the first antenatal visit, and in the visit.
Sorry about that. I will mute
So yes, I hope I answered your question.
Yeah. All right. Sorry about the interruption. I think it was inadvertently unmuted. Yeah, so we have one more from Alfred. Some pregnant women noted some pregnant women noted the role of their spouses as a contributory factor. Is the team therefore looking at ways to include spouses and sensitizing them towards the spouses to salvage the situation? This comes in from Alfred Aqua.
Yes, sure. As like disposal relationship and also support during pregnancy and postpartum, like most of women shared a concern about even their partner support after giving labor. So I think it's valid to just include the spouse in like sensitization for the scale.
All right. And then Dr. Frank Abu follows up with whether the scale has been validated elsewhere, apart from Austria and Ghana.
It was validated, like it was adapted in Turkey and validated there. And also there is an adaptation in Japanese population and adapted, validated there. And also there is some European countries that did also adaptation to validate in their population, like Germany, for example, like published and adapted and validated a new scale for them.
Excellent. Darius asks which of these factors were principally contributory to anxiety. Maybe the top 3 factors is looking at that.
I didn't get this question again, please.
So asking about the top 3 factors that contributed to anxiety from the research findings.
Okay, like it's not the aim of our like it's not the aim for this study to see what is the top related factors for, like, you know, it's just to validate the scale.
Great. Nafisa says, please, how can we reduce this pregnancy-related anxiety?
So this means that how could we intervene? And to make an intervention, also again, it needs to be clinically valid. And then after that, you could start to have research-based interventions to just decrease pregnancy-related anxiety. So there could be interventions like, for example, if early detected, to just ask for psychosocial consultation or so on, but this need to be studied in a wider range.
Okay. And then the last one from Helena, how is the scale being used during their first visit? I don't get it, but I guess it's asking how the scale can be used during the first visit, the booking visit.
It's a questionnaire, so you could just give them it in a paper or maybe like face to face.
Yep.
Yeah.
All right. Thanks so much. I think that's it with regards to the questions in the chat box. And we are grateful to you, Quanitam, for making time to take us through this pregnancy-related anxiety scale. I'm sure it's an eye-opener for a couple of us in rural practice, and definitely would help us in being on the lookout. Even the awareness alone of it is important, so that then we can identify those pregnant women who do have this, and will definitely help us to improve upon our maternal health, which is one key feature of Ghana Medical Health. That's how come we dedicate a whole project called the Maternity Service Agenda towards improving maternal and newborn care. So we are grateful to you, and thanks to the entire research team for making this possible. Have a great day, and to our participants online and everyone here in-house, we are grateful that you could join us this week for this webinar. And subsequently, like you always know, on Fridays, we would bring you a couple of these webinars by way of capacity building, by way of improving upon our knowledge about maternal and newborn care. All the best, Juanita, and have a great day.
Thank you. Thank you.
All right. Bye-bye to everyone. Have a great day. God bless. Bye.